Amelogenesis imperfecta is a congenital disorder that affects both the structure and appearance of the enamel of the teeth. This abnormality causes the teeth to appear very small, discolored, pitted or grooved, and prone to rapid wear and breakage with early tooth decay and loss. Amelogenesis imperfecta can have different patterns of inheritance, depending on the gene that is being altered. In most cases, it is caused by a mutation in the FAM83H gene and are inherited in an autosomal dominant pattern. This type of inheritance means that one copy of the altered gene in each cell is sufficient enough to cause the disorder to manifest. There are three categories of your amelogenesis imperfecta. First one is your hypoplastic amelogenesis imperfecta, in which inadequate deposition of enamel matrix can be observed. It can be visually characterized by its thinness, malformation, lack of touch, and a hard, glossy appearance. And for the second one, we have hypomineralization amelogenesis imperfecta, in which deficit in the process of mineralization of the dental enamel matrix can be observed. It can be visually characterized by its soft, cheesy enamel that is lost diffusely and rapidly after eruption. And for the third one, we have hypomaturation amelogenesis imperfecta, in which there's an adequate deposition and mineralization, but there's an inadequate maturation of your crystallites. This type of amelogenesis imperfecta can be further divided into two: the pigmented and the snow-cap. For the pigmented, the enamel appears mottled and brown, and for the snow-cap, zone of white enamel appear on the incisal and occlusal edges. Issues associated with your amelogenesis imperfecta include suboptimal oral aesthetic, dental hypersensitivity, and a diminished vertical dimension. It has also been linked to numerous dental conditions such as impacted teeth and abnormalities in tooth eruption, congenital absence of teeth, calcification of dental pulp, disruption of tooth roots and crown, excessive cementum development, malformation of tooth roots, and taurodontism. Patients with amelogenesis imperfecta exhibits a heightened likelihood of experiencing dental caries and plaque buildup. This is due to the abnormalities in the enamels, specifically it being rough, which causes food entrapments and consequently plaque buildup. Additionally, they also experience anterior open bite, which is a common malocclusion problem often observed in individuals with amelogenesis imperfecta. Treatment options for patients with amelogenesis imperfecta includes microabrasion, composite veneers, porcelain laminate veneers, onlace, gold or stainless steel crown, metal ceramic crown, and lastly, all ceramic crowns. The treatment options mentioned earlier are influenced by various aspects that will most likely determine its success. One being patient's age, second is nature and extent of illness or ailment, third is internal consideration, and lastly is socioeconomic standing.
So these are the collaborative efforts and communication strategies employed by dental teams in this case. First, we have here the interdisciplinary collaboration. Second, the case discussion and treatment planning. And patient education and communication. Interdisciplinary collaboration. The dental teams include general dentists, prosthodontists, and orthodontists. These professionals work together in this case, combining their expertise to develop a comprehensive treatment plan for the patient. With the case discussion and treatment planning, the dental team holds regular case discussions to review the patient's condition, exchange information, and discuss potential treatment options. Next, we have here the patient education and communication. The dental team ensures that the patient understands the condition, treatment options, and the expected outcomes. They explain the benefits and potential risk of each treatment, helping the patient make informed decisions. We also have here the treatment sequencing and coordination, regular progress updates, and referrals and consultations. With the treatment sequencing and coordination, since this case has different dental treatments employed such as orthodontic treatment, restorative procedures, and prosthodontic care, the dental team collaborates to sequence and coordinate these treatments effectively, ensuring that each step is planned and executed properly. With the regular progress updates, the dental team communicates regularly with the patient to provide updates on the treatment progress. This helps manage expectations and ensures that everyone involved is well informed throughout the treatment process. Lastly, the referrals and consultations. This allows for the expertise of various dental professionals to be utilized for the best possible outcomes. So let's proceed with the procedures and techniques. It has been stated in this case that at the first session, the patient was referred to the pediatric and operative departments for initial restorations to protect the remaining tooth structure against further wear and sensitivity by using resin composite veneers for the anterior and premolar teeth and stainless steel crowns for the second deciduous molars and first permanent molars. Restorative dentistry focuses on repairing and restoring the teeth affected by amelogenesis imperfecta. Various techniques and materials may be used, such as tooth-colored composite fillings, porcelain veneers, or crowns. In this case, resin composite veneers for the anterior and premolar teeth and stainless steel crowns for the second deciduous molars and first permanent molars were used. These restorations can improve the aesthetics and functionality of the affected teeth and to protect the remaining tooth structure against further wear and sensitivity. Next, we have here the orthodontics. It has been stated in this case that after getting an entire permanent dentition, the subject was referred to an orthodontist at the age of 14 to treat his underlying malocclusion. Orthodontic treatment was performed and initiated in this case to correct malocclusion of teeth and improve the overall bite and to improve the soft tissue profile. Fixed orthodontic appliances, quad helix appliance, intermaxillary elastics, and other orthodontic appliances are used in this case to gradually move the teeth into their proper positions. The posterior crossbite was corrected with maxillary expansion using a quad helix appliance, combined with buccal crown torque of the maxillary posterior teeth and lingual crown torque of the mandibular posterior teeth. The open bite was corrected using intermaxillary elastics.
The teeth number 5, 12, 22, 27 were prepared for ceramic veneers using a chamfer margin and incisal bevel preparation. Tooth preparation was performed using a labial silicone index made from a diagnostic wax as a guide. The final impression was taken using polyvinyl siloxane. Bite registration and phasal transfer were performed. A palatal silicone index was used to fabricate temporary veneers using resin composite. Final working casts were mounted on a semi-adjustable articulator with a customized anterior guide table. Ceramic veneers were made from pressed ceramic with a layering of veneering ceramic to mimic the natural indirect resin composite veneers were performed on the upper second premolars and all lower premolars, number 4, 13, 20, 21, 28, and 29. All of the teeth were etched with 37.5% phosphoric acid. Optibond FL bonding agent was then applied. Resin composite was chosen as the restorative material. Any exposed dentin was restored with resin composite. After all treatment had been carried out, the patient was satisfied with the outcome for both aesthetics and function in Figure 12. Upper and lower holly retainers were made to maintain the tooth alignment in Figure 13. Furthermore, upper and lower trays for GC tooth mousse were made to help prevent dental caries. The patient was introduced to wear these trays at least 3 minutes after brushing. Following the manufacturer's recommendations in Figure 14, the patient was recalled at post-operative intervals of 1 week, 1 month, 3 months, 6 months, and 1 year. Prosthodontics involves the design, fabrication, and placement of dental prostheses to replace missing or damaged teeth. In cases of severe AI like this case, the dental team may consider options like dental implants, bridges, or dentures to restore the patient's ability to bite, chew, and speak properly. So the procedures and techniques. The first is tooth preparation. The tooth numbered 5, 12, 22, 27 were prepared for ceramic veneers. The dental team used a chamfer margin and incisal bevel preparation technique. This involved remaining a small amount of tooth structure from the front or the labial surfaces of the affected teeth to create space for the veneers. The second is labial silicone index. This is to ensure accuracy and consistency during tooth preparation. A labial silicone index was created. This index was made from a diagnostic wax-up, which is a model or mock-up of the desired final outcome. The silicone index served as a guide for the dental team to precisely replicate the desired tooth shape and contour during tooth preparation. Third is final impression. After tooth preparation, a final impression was taken using polyvinyl siloxane material. Polyvinyl siloxane is a type of dental impression material that provides excellent detailed reproduction and dimensional stability. It captures the prepared teeth and surrounding tissues to create an accurate representation of the patient's mouth. Fourth is bite registration. A bite registration is a process of capturing the relationship between the upper and lower teeth when the patient bites down. This is typically done using a dental material that hardens into a semi-flexible state. The purpose is to record the patient's bite position accurately. 5. Face bow transfer. Face bow is a device used to transfer the relationship of the patient's jaws to a semi-adjustable articulator. It consists of a frame that attaches the patient's maxillary arc and records the position of their TMJ. This formation helps replicate the patient's jaw movements on the articulator during dental work. Sixth is palatal silicone index. It is a custom-made device used to replicate the shape and position of the patient's teeth and gums. It is made using a silicone material that is placed on the patient's teeth and cured to form an accurate representation of the palatal roof of the mouth area. Seventh, semi-adjustable articulator. This articulator is a device used in dentistry to stimulate the movement of the patient's jaw. A semi-adjustable articulator is a type of articulator that allows 4 adjustments to be made to replicate the patient's specific bite and jaw movements. The final working casts are mounted on the semi-adjustable articulator for further analysis and preparation of the final restorations. Eighth, customized anterior guide table. An anterior guide table is a component of the articulator that replicates the patient's anterior front teeth and their biting and chewing patterns. A customized anterior guide table is specifically designed to match the patient's individual dental anatomy, allowing for accurate representation of their occlusion, how their teeth come together.